Thank you very much for the privilege to speak today to moderators and the society. These are my disclosures. And we'll talk today about role of sentinel lymph node biopsy in esophageal surgery. This is kind of objective of discussion today. So really, probably the founding father of modern surgery is William Stewart Halstead, pioneering surgeon, trailblazing surgeon, the surgeon who performed first blood transfusion on his own sister, bleeding from uterine bleeding, and first cholecystectomy on his mother. And also he gave a hope to patients with breast cancer performing first mastectomy in 1892. However, his meticulous technique brought the whole host of complications, restricted range of motions, chronic pain, lymphostasis, and this is where the idea of sentinel lymph node biopsy came through to identify the first lymph node and a cascade of lymphatic drainage of the cancer. And if there is evidence of metastatic disease in a sentinel lymph node, those would be the patients who you would perform lymphadenectomy, subjecting them to potential complications, but minimizing the pool of those patients. Esophagus turns out to be a little bit more complex organ than the breast, located deep inside the chest, spanning several body cavities, neck, chest, and abdomen, extensive network of lymphatic drainage, and pretty much unpredictable drainage. And since 2010, 7 edition of TNM, it is the number of lymph node is a staging for end parameter and not their location. And involvement of lymph node metastasal disease essentially is the most negative predicting factor in staging of the patient with esophageal cancer. So how do we deal with that? Well, we perform extensive lymphadenectomy, and it has been shown in the literature that more lymph node removed, the better oncologic outcomes. However, this extensive dissection brings the whole host of immediate and late complications. From esophagectomy complication consensus group, the morbidity of esophagectomy is approaching 65%. And even in the best hands in the country, still chlamydian grade 3 and 4 complications approaching 25%. And even for those patients who survive, their quality of life is still poor. Although this paper look at the difference between men and women, however, health-related quality of life in patients with esophagectomy is quite poor. And with aging population, not surprising, outcomes in octogenarians is even worse. This is our paper on NCDB database. So for that reason, in 2010, the group from Europe, Christianel, put this study looking at endoscopic resection of early mucosal adenocarcinoma versus surgery. Unsurprising, as endoscopic resection patients did significantly better compared to surgical group. However, there was several late recurrences that were absent in a surgical group. And since 2015, endoscopic resection became a part of the staging workup for esophageal cancer. This is our paper from STS database. And about 30% of patients now undergoing esophageal resection as a part of the staging workup, not to mention those patients who undergo endoscopic resection with the curative intent. However, the devil is really nodal metastasis. Again, Christianel group looked at the rate of nodal metastasis in the patients undergoing endoscopic resection, and low-risk LR group of patients and high-risk, low-risk was T1A, no lymphovascular invasion, low grade, and the rate of nodal metastasis was low, 2%. In the high-risk patients was up to 10%. And Boris Cepesi showed that even in T1B patients, rate of lymph node metastasis can be as high as 50%. What's interesting, this paper looking at occult lymph node metastasis. So these are the patients who underwent esophagectomy, and pathology stated that this is N0, no nodal metastasis in this patient. However, the standard processing of the lymph node usually involves cutting lymph node at 1 to 3 levels. If you have 50 nodes, it's already 150 specimens for pathologists to look at that. But there are micrometastases defined as tumor deposits lived in 2 millimeters, and also isolated tumor cells. And prognosis of those patients are even worse. And what was the rate of occult nodal metastasis? Up to 20% in this paper. For that reason, sentinel lymph node biopsy started to be introduced into esophageal surgery around 2000. Several papers were done. I'm not sure how much time I have, but basically using of technetium, colloid, and gamma probe, some regional metastasis and sentinel lymph nodes were successfully identified up to 88 to 90% of the patients, not bad. That was corroborated by the group from UK. Unsurprisingly, majority of the sentinel lymph nodes were lower paraesophageal or upper abdominal lymph nodes. This is distribution by the number of nodes, and on the right side, total radioactivity in lymph nodes. And other tracers that have been used is ICG that we talk a lot about, and this is meta-analysis of 6 papers looking at ICG, low-volume patient group, 65 patients in 6 studies. However, overall detection rate, ability to find sentinel lymph nodes approached 85–90%, as well as sensitivity, and specificity is low because obviously not every sentinel lymph node would have metastasis in them. And this is most interesting paper published about a year ago, March 2023. Paper comes from Netherlands. 10 patients where patients underwent endoscopic resection, and about 2 to 6 months later, patients were brought in, had ICG and technetium colloid injected around the tumor, and on a scintigraphy, the metastatic pattern or location of sentinel lymph nodes were identified, and then patient was taken to the operating room, and biopsy of those patients was performed of those sentinel lymph nodes. 10 patients, 2 patients had metastatic disease in those lymph nodes, in sentinel lymph nodes, and both patients selected to proceed with observation without esophagectomy. So this is not really sentinel lymph node, and it is a little bit out of topic, but I feel compelled to mention it. It is currently approved only in GYN and lung cancers. This is actually tumor-specific fluorescent, where the fluorescein molecule is linked to antibodies to folate receptors on the tumor cells, and they link to tumor. Currently, it is approved, as I said, in lung and OBGYN, but I'm sure that there will be other new agents. I'm unaware if it is used in esophageal cancer, but this is IV drug that is given preoperatively, and it binds to the tumor and will localize it in the lung. And I'm sure at some point it will trickle down to all the other malignancies. Also identify that in the lymph nodes. So with that, what is the role of lymph nodes? It is potentially surveillance of patients undergoing organ-preserving procedures, endoscopic resection. It is potentially guided extent of lymphadenectomy in patients who undergo an esophagectomy based on sentinel lymph node location. It is rigorous assessment of the sentinel lymph nodes. They are processed different from all the lymph nodes. More careful, more slices, and more studies, which otherwise just impractical to do on every lymph node. And potentially in the future, nobody talks about it, but if you have complete response in the primary tumor bed, there might be another application for sentinel lymph nodes. There is currently a trial going from MSK, run by Daniela Molina, for those who are interested. And with that, this is end of my talk. I live and practice in Galveston, where people come for vacation. I think only Miami people can rival my location. Thank you very much.